Okay. So starting with a few important points about the BCG vaccine. So BCG, the strains of vaccine usually used are the Copenhagen, Danish 1331 strain, okay, or the Pasteur strain. Then some important points related to it. It is a light sensitive vaccine, so that is why it is applied in dark colored ampoules, okay. So it is light sensitive, live vaccine, and supplied in a lyophilized or freeze dried form as powder. So L, L and L, okay. Now what is a diluent which is usually used for BCG? So normal saline is to be used as diluent, because if you use distilled water, it acts as a irritant to the skin, okay. So normal saline is to be used as diluent, and the route of administration of BCG, so what is recommended is 0.05 ml of BCG is to be given intradermal route in the neonatal period, okay, intradermal route. And BCG induces cell-mediated immunity. So it is not interfered by the immunoglobulins or the antibodies which come in the baby from the mother. Okay, so that is why we can give it so early on in life. So it induces cell-mediated immunity. And does BCG protect against TB infection? No. Does BCG protect against pulmonary TB? No. So BCG mainly protects against more severe forms of TB like TB meningitis and disseminated TB. Okay. So BCG mainly protects against severe forms of TB like TB meningitis or disseminated TB. But it does not protect against pulmonary TB or TB infection. Okay. So these are some important points to remember about the BCG vaccine. Moving on to the polio vaccine. There are two main types of vaccine. So one is the oral polio vaccine or Sabin, which is the live vaccine. Another is the injectable polio vaccine or Salk vaccine, which is the killed vaccine. Okay. Now, OPV currently being used in India and almost all over the world is the bivalent vaccine. So, OPV used currently is bivalent, which contains P1 and P3 strains. So OPV2 was actually globally discontinued in April 2016. Okay, globally discontinued. In April 2016. Another very important thing is to remember is, previously in the national immunization schedule, we had only the OPV vaccine, not the IPV. But now, after this P2 vaccine has been withdrawn from the OPV, WHO now recommends that at least one dose of injectable polio vaccine should be incorporated in all the national immunization schedules. Okay. So, WHO now advocates at least one dose of IPV to be incorporated in national immunization schedule. So that is why we have 2 doses of fractional IPV in the immunization schedule now. So WHO no longer advocates OPV only schedule, Because IPV protects against the poliovirus strain 2 also and against VAP also. IPV protects from wild poliovirus as well as polio caused by circulating vaccine derived poliovirus strain 2. Okay. So that is why IPV 2 doses fractional have been incorporated in our national immunization schedule as well. Okay. Now what do you mean by VAP and what do you mean by VDPV? Okay, a little bit idea we need to have about these terminologies. So VAP or vaccine associated paralytic poliomyelitis. Vaccine associated paralytic poliomyelitis basically refers to cases of AFP cases of AFP which have residual weakness 60 days after the onset of paralysis, which have residual weakness 60 days after the onset of paralysis, and from whose stool samples vaccine related but not wild poliovirus has been isolated. So from whose stool samples vaccine related but not wild poliovirus have been isolated. Okay. Now what do you mean by VDPV or vaccine derived poliovirus? So what do you mean by VDPV or vaccine derived poliovirus? So VDPV arise basically due to mutation and recombination in the human gut. Okay. So arise due to mutation and recombination of vaccine derived polio virus in human gut, which are 1 to 15% divergent from the parent vaccine strain. Okay. Okay. So these are some important points that we need to remember about polio vaccine. Moving on to hepatitis B vaccine. We already mentioned that hepatitis B vaccine once 0 dose has been advocated, which should be given within 24 hours after birth. Thereafter, hepatitis B vaccine is a part of the pentavalent vaccine, which is given at 6, 10 and 14 weeks. Okay. So this hepatitis B vaccine, the role of the birth dose is basically to prevent hepatitis B transmission from mother to baby. So the birth dose or the 0 dose is given to prevent Hep B transmission from mother to baby. So it should be given within 24 hours of birth. Okay. Now the management of a baby born to hepatitis B positive mother is very, very important. Okay. So basically we need to look at the status of the mother and decide the management or intervention that is required for the baby. So in order to prevent the transmission of hepatitis B from the mother to the baby, what all needs to be done? Let us see. And it is often asked in MCQs. right? So if the mother is HBsAg positive, you need to give both hepatitis B immunoglobulin and hepatitis B vaccine within 12 hours after birth. And complete hepatitis B vaccine at 2 and 6 months. Okay. If the mother's HBsAg status is unknown, then again you have to give hepatitis B vaccination within 12 hours. And you send the HBs antigen of the mother. If it comes out to be positive, then we can give hepatitis B immunoglobulin within 7 days of life. Okay, and complete the hepatitis B vaccination schedule at 2 months and 6 months. While if the mother is HBsAg negative, then you need not do anything separately. Just give the complete vaccination series including the dose at birth. Okay. So that is about prevention of the hepatitis B transmission to the baby. Now moving on to DPT vaccine. So DPT vaccine protects against diphtheria, pertussis as well as tetanus. Okay. Now most of the adverse effects of DPT vaccine are due to the pertussis component. Most adverse effects are due to pertussis component. Okay. Some severe adverse effects include persistent inconsolable screaming or cry, persistent inconsolable screaming, seizures, hypotonic hyporesponsive episodes, encephalopathy and anaphylaxis. Okay. Some contraindications to DPT vaccination include progressive neurological illness. So if a child has got progressive neurological illness, anaphylaxis to a previous dose of DPT vaccine, or encephalopathy within 7 days of vaccination. Okay. So catch-up vaccination, if the child has presented at less than 7 years of age, we give DPT at 0, 1 and 6 months. While if the child presents at greater than equal to 7 years of age, then we give Tdap at presentation followed by TD at 1 and 6 months. Okay. That is about some important points about DPT vaccine. Now moving on to the measles and rubella vaccine. So measles vaccine we know is a live attenuated vaccine. The strain of measles vaccine that is used is the Edmonston Zagreb strain. Edmonston Zagreb strain. The diluent used for measles vaccine is distilled water. Route of administration is subcutaneous. So previously at 9 months measles vaccine and 16 to 24 months MMR vaccine was recommended. But now what is recommended is the use of measles and rubella vaccine both at 9 months and 16 to 24 months. Okay. So as per the latest national immunization schedule, MR vaccine at 9 months and 16 to 24 months. However, IAP recommends 3 doses of MMR vaccine at 9 months, 15 months and 4 to 6 years. So IAP recommends 3 doses of MMR vaccine at 9 months, 15 months and 4 to 6 years. Some important side effects of measles vaccine or adverse effects. Apart from local pain and tenderness, there can be a mild measles-like illness and there can even be thrombocytopenia. Okay. So adverse effects include local pain or tenderness, mild measles-like illness and thrombocytopenia. Okay. Moving on to a little bit about another important vaccine, that is the pneumococcal vaccine. Now pneumococcal vaccine, we have a pneumococcal conjugate vaccine. And we have a pneumococcal polysaccharide vaccine. Okay. The pneumococcal conjugate vaccine which is currently available is 13 valent. That means it covers against 13 serotypes of pneumococcus. While the pneumococcus polysaccharide vaccine covers against 23 strains of pneumococcus. But you know, this pneumococcal conjugate vaccine can be given even at less than 2 years of age. But pneumococcal polysaccharide vaccine is immunogenic only beyond 2 years of age. Okay, and it has got low immune memory and does not provide herd immunity also. Low immune memory, no herd immunity. Okay. So pneumococcal conjugate vaccine has been included in the national immunization schedule in some states currently. But polysaccharide vaccine is recommended to be given only in certain special situations, like in an immunocompromised child, okay, or in a child who is splenectomized, okay. Only in special situations the polysaccharide vaccine is recommended. So recommendation about immunization. Prior to splenectomy. So, you know, if we are planning splenectomy, we should immunize the child against, at least in addition to the routine immunization, we should immunize the child against capsulated organisms. So we should give Hib, pneumococcal and meningococcal. Hib, pneumococcal and meningococcal vaccines at least 2 weeks before splenectomy. at least 2 weeks before surgery. Okay. Moving on to a little bit about rotavirus vaccine. So it is a live oral vaccine which has now been introduced in the national immunization schedule as well. So in the national immunization schedule, it is recommended to be given at 6, 10 and 14 weeks. Okay. And maximum age of catch-up vaccination is 1 year according to the national immunization schedule. But it should always be initiated with the first dose of OPV vaccine. If it has not been started along with that, then the other 2 doses are usually not given as of now. Okay. The strain of rotavirus vaccine which is used in the national immunization schedule is the 116E strain that has been isolated from India itself. Okay. So that is the one which is introduced in the national immunization schedule. A very important adverse effect of rotavirus vaccine is the increased risk of interception. Okay. About the hepatitis A vaccine. So hepatitis A vaccine, as we already mentioned, 2 types of vaccines are available. One is the live vaccine, for which only single dose is sufficient, which is to be given at 12 to 23 months of age. Another is the inactivated vaccine, for which 2 doses are recommended 6 months apart. So 2 doses 6 months apart, starting at 1 year age. Okay. IAP recommends hepatitis A vaccine to be given to all healthy children. Okay. A little bit about influenza vaccine. So influenza vaccine, again we have inactivated vaccines or live attenuated vaccines which are available. So inactivated vaccines, which can be whole virus or split product or subunit vaccine. Okay. Live attenuated vaccines, which can be given as nasal sprays, which are not available in India currently. Okay. The regime of influenza vaccine which is recommended for all healthy non-pregnant individuals is 2 doses intramuscularly, 2 doses intramuscularly 4 weeks apart for the first dose, followed by 1 dose annually. So every year the strain of influenza virus is revised based on the prevalent strain in that particular time frame or in that particular zone. Okay, and based on that, annually the vaccine strain is updated. So that is why annual dose of influenza vaccine is required. Now in 2018-19, the influenza vaccine which had it incorporated which all strains, we need to know. It can be asked in the MCQs. Strains in 2018-19 influenza vaccine are the type A Michigan H1N1 strain, type A Singapore H3N2, type B Colorado Victoria lineage, and type B Phuket Yamagata lineage. So quadrivalent influenza vaccine was recommended for this season. Okay. A little bit about typhoid vaccine. So typhoid vaccine, again, previously the vaccine that was available was only the VI capsular polysaccharide vaccine. VI capsular polysaccharide vaccine. So as it is a polysaccharide vaccine, it is not immunogenic less than 2 years of age. Not immunogenic less than 2 years of age, and it has no immune memory, and the efficacy is only 50 to 60%. So no immune memory, efficacy 50 to 60%. Recommended only at greater than equal to 2 years of age. Followed by revaccination every 3 years because poor immunological memory. So followed by revaccination every 3 years. That was what was recommended. Okay. Now currently we have a typhoid conjugate vaccine which is available. So nowadays a typhoid conjugate vaccine is also available which can be given 6 months age onwards. Okay. And a single dose is usually sufficient. And the overall efficacy is around 90%. So this is a better vaccine which is now being increasingly used. Okay. Now, what to do if a child already has a history of enteric fever? Child already developed typhoid and he was unimmunized for typhoid. Do you need to vaccinate him? Yes. So, a typhoid infection may not necessarily lead to immunity in the child. So, an unimmunized child who had enteric fever should be given typhoid vaccination 4 weeks after full recovery. Should be given typhoid vaccination 4 weeks after full recovery. Okay. So that is about typhoid vaccine. Moving on to a little bit about varicella vaccine. Now this varicella vaccine against the chickenpox is also a live attenuated vaccine. So it is a live attenuated vaccine, and the strain which is used is the Oka strain, sometimes asked in MCQs. The dose is subcutaneous. 2 doses are recommended at 15 months and at 4 to 6 years of age. IAP recommends varicella vaccine to be given to all unimmunized children, to all healthy children with no previous history of varicella. Okay. And interestingly, this varicella vaccine can also be used for post-exposure prophylaxis. So if a child has got exposed to varicella, we can use this vaccine for post-exposure prophylaxis, preferably within 3 days of exposure. So for post-exposure prophylaxis, preferably within 3 days of exposure. Okay. But potentially up to 5 days of exposure. Right. So that is about the varicella vaccine. Moving on to a little bit about HPV vaccine or human papilloma virus vaccine. So 2 types of recombinant DNA vaccines are available. One is the quadrivalent vaccine called the Gardasil, okay, which has the HPV strains 6, 11, 16 and 18, while another is the bivalent type or Cervarix, which protects against the strains 16 and 18. HPV vaccine gives 99 to 100% efficacy. So 99 to 100% efficacy against vaccine type related genital warts and vaginal and vulvar neoplasia. The minimum age at which this vaccine can be given is 9 years of age, while catch-up vaccination can be done between 13 to 45 years of age. Ideally, it should be initiated before the sexual debut of any female. Okay. So these are some important points about some of the vaccines that are important for our MCQs.